Awesome. So I think somebody put in the chat box that it was 12, like 12 degrees is what we're talking about.
No, I'm pretty sure in Grangeville, Bill is saying it snowed 12 inches.
Oh, got it.
Yeah.
Got it.
I'm sure you're familiar with that in Texas, but yeah.
Yeah. So my name's Ginger Locke. I'm here in Austin, Texas, as Sean referenced, and I taught, it seems like maybe a month ago, we talked about abdominal trauma, and I was looking up on YouTube just to find another lecture that I have up from a conference where I spoke about performance under pressure. And I noticed, Sean, you had posted that video on YouTube. That was pretty cool to have it pop up when I searched Ginger Locke. So thanks for doing that. So if you didn't see that one, you can, I guess, go back and look at that because it's out there. It looks like these are going to be posted on YouTube. So I teach paramedics in Austin, Texas, and we've been doing weird virtual learning since the pandemic started. And yeah, I've been doing a lot of sitting right here. Actually, I taught earlier today for about 2 hours. We were doing endocrine assessment. So pretty dense topic of the endocrine system. Tonight's topic, I actually picked this topic, the art of auscultation. I'm going to start sharing, I think, now. It's possible I lost control of, nope, there we go. All right. So what does that look? Is that a blank screen or is it title screen, Sean?
That is a blank screen.
All right. Now it looks like a beautiful.
Yeah, it looks like a beautiful beach. There you go. There's your title screen.
That's what I wanted. So the title is The Art of Auscultation, and this topic is a tricky one because I don't love auscultation. I don't love using a stethoscope. I don't, over the years, I found that I use my stethoscope less and less, it seems. I've been practicing in EMS for about 20 years, and it just seems like more and more I pull it out to get a blood pressure, and that's about it. We teach auscultation in our program, and I think there is an art to how to do it. And I actually purposely picked this lecture because I wanted to refresh on it and remind myself, kind of getting back to the basics and the fundamentals of how to auscultate properly. And so when I say auscultate, what I mean is listen, right? And the body makes all these different sounds. And we are used to listening with a stethoscope. There are some things we can hear audibly, like wheezing and things like that when you walk in the room. But usually the word auscultate means with the stethoscope. And about, let's see, 10 years ago, we had something really cool happen in our program. We really heavily emphasize auscultation. We teach heart tones. We spend like a whole 2 days for them to learn heart tones and all of this. And it gets pretty deep. And we have this one scenario where a professor pretends to be having a thoracic aortic aneurysm. And I kid you not, this is a true story. We tell this story to incoming students because it really emphasizes the value of auscultation. And I was reminded of this story in preparing for this lecture because I wanted to share it with you. And the story is of this. I'm going to actually stop sharing here for a bit. Let's see if I can see you guys. The story is of a student running this scenario. And normally the students just go through the motions of pretending to auscultate, right? They'll just kind of go and they'll say, what do I hear? But this particular student listened to heart tones, and it was a thoracic aortic aneurysm scenario. And so we were intending to tell them, you know, what goes with that is a harsh systolic murmur. right? Because if the aneurysm's close to the aortic valve, where the blood comes out of the left ventricle into the aorta, you can get a little swooshing sound, right? Because there's turbulent blood flow from this aneurysm. So we almost always, we just tell them, they pretend to listen to heart tones, and we tell them, yep, you hear a harsh systolic murmur. Well, this student, who currently works for Austin Travis County EMS, he's a graduate of our program, he listened that day. He actually listened. And what he heard was a pretty quiet but very apparent murmur on our professor. And a murmur is basically, like a sound that is not sharp. So most heart tones, you get a very clear lub dub, right? S1, S2, real sharp sounding, kind of like a drum. I know you've heard it. If you've just like laid your head on someone's chest, you've heard a lub dub. He heard a little dub, right? And he was like, hey, I actually hear something in there. And this professor, who had retired from Austin Travis County EMS, he does not mind me sharing this story because it's kind of well known in Central Texas. He went and got it checked out. And it turned out he had a thoracic aortic aneurysm, a stable one, but a new aneurysm nonetheless. And he ended up in open heart surgery. This is a true story. It almost seems too crazy to be true, but he ended up in open heart surgery within a week of that student finding that heart murmur. And so that's kind of been a legacy of our department, something that we tell all students about the value of auscultation. It may not always be this kind of acute, immediate need, something that you have to do, right, to save someone's life. But sometimes just incorporating auscultation into your just kind of routine physical exam, you can detect underlying kind of chronic things that need pretty quick intervention. So that's my attempt to get you to buy in a little bit in talking about auscultation. As I said, it's something that I've kind of just moved away from, and I think it's because I've gotten into ultrasound and just I quit trusting it, or I didn't practice it enough. But this lecture kind of re-sparked for me to kind of get back to doing it on every patient, right? The stable ones that you've got time with, just spend a little time listening to, if nothing else, lung sounds and heart tones. If you listen to lung sounds, you're right there. You might as well just take a listen to the heart as well. So I'll talk about that. The topic is auscultation, but to me I actually picked this topic from a list that Sean sent. It was just kind of a list. I was like, hey, I think that one seems good. But I don't know that it's enough to really fill up a whole hour and a half. So I've thrown in also some vital sign information. And that's just getting back to the basics, like how to take a blood pressure well, right? How to do it in a way that maybe makes you just, if I can discuss all the principles of it, maybe it makes you just a little bit faster at doing it, or a little bit more confident on the ones that are tough. So I want to pick through back some of just those very foundational kind of BLS vital sign stuff as well. Because when's the most likely time you're going to pull out your stethoscope on a call? It's taking a blood pressure, right? So I've thrown some other stuff of that in there as well. All right. Let's see how this goes. Should look like the ocean. Now it looks like a title slide. So what I want you to do first, oh, maybe it doesn't. Does it look like a blank slide, Sean?
No, I see something that says chat box. What on the body can be heard with a stethoscope?
Thank you. Good. So I want you to think to yourself and type in the chat box, what all can you hear with the stethoscope in the human body? What organs can you hear? Right? Obviously the heart and lungs, but there's more. Good. Yeah, heart, lungs, the stomach, the GI tract. Good. Crepitus under the skin. I'm wondering if you're thinking like subcutaneous emphysema there. The joints and broken bones. I love that. You can absolutely hear the crepitance of broken bones. There've been studies about that. What else can you hear? Here, I'll give you a picture of the human body to look at. I kind of hope y'all don't come up with all of them, because then I'll feel like I'm actually sharing something with you that you don't already know or that you've forgotten, right? This is continuing education. So it's about learning new things, but it's also just about kind of knocking the rust off of stuff we've forgotten. Yes, bruise. So bruise is spelled, oops, maybe this to go to everybody. So bruise is spelled B-R-U, since you asked, I-T-S. And bruise is turbulent blood flow. And so that murmur that that student heard today is actually technically a bruit. And one place that you may have heard a bruit before, probably the easiest place to hear and a great example of bruit is when people have dialysis fistulas, right? In a fistula, they sew together an artery and a vein, and it makes that vein just like get really, really dilated. So it makes it easy to cannulate for, 2 or 3 times a week dialysis. Because they've put an artery with a vein, that artery is under high pressure and it hits a vein that's not really ready for that, and you get turbulent blood flow under that. All right, so here's my list. And this was just a fun exercise for me of thinking, like, what all can I hear? So the carotid arteries you wouldn't normally hear unless there's bruise under there. And that happens when there is narrowing of the carotid arteries. So as people age, they can get some hardening or narrowing because of plaque in the carotid arteries. And you can detect that just by placing your stethoscope over the carotids. You can listen to the trachea. Maybe put in the chat box, what would you hear over a trachea? You can kind of imagine like the harsh air coming, perfect. Harsh air just coming through with normal breathing. But if something's in there or it's narrowed, right? If it's narrowed from foreign body airway obstruction or swelling from inhalation burn or allergic reaction, the stridor is usually audible because it's like there's very little between the trachea and the outside world, just a little skin, right? But it may be more subtle. So you can place your stethoscope directly on a trachea and listen for stridor. We also put the stethoscope on a trachea when we put things in like an LMA or a King LT to listen to make sure there's no, like these supraglottic airways, to make sure there's no leaking around the cuff. So the auscultation of the trachea does happen. The main stem bronchi, right, the left and right main stem bronchi, these major airways, we listen to those. What would you hear in there? Imagine these huge airways. They don't really have the opportunity to narrow, even when they're swollen and stuff. They don't narrow the way like the glottic opening can. So you don't get stridor unless there's something in there, right? So if they've aspirated foreign body something into one of the main stem bronchi, you could get stridor there, or you can get what's called rhonchi, and I'll talk more about that later. We listen to the alveoli, right? What can you hear in the alveoli? At the end of the lung, right? The little air sacs at the end. What might land there? Yeah, rales. And rales represents, thanks, Eric. Rales represents, another word for rales is crackles. And it sounds kind of like popping open, or kind of crunchy, crackly, I think is a good word. And it represents when alveoli have collapsed, them popping back open because it's so watery in there, right? From pulmonary edema, or just the lungs themselves are watery. When they pop back open, you hear a little bit of kind of bubbling, cracking. You can hear rails in the alveoli. The pulmonary pleura, that's like the linings of the lungs, and you can get inflammation of those linings. So when you put your stethoscope on the chest, if you hear what sounds like kind of friction with the breathing, like rubbing together of rough leather, kind of sandpapery, that can indicate what's called a pleural friction rub, where they're rubbing together. We listen to the heart valves. That's what we're hearing when we listen to heart tones. We're listening to them snap closed is the theory. Nobody knows for sure, but we think it's them closing that generates the lub-dub. You could hear the pericardial sac if it was irritated, again, kind of like the pleural lining. If the pericardial sac is, if they have pericarditis or inflammation of that lining, you could hear kind of almost like it's called also a friction rub, pericardial friction rub, again, kind of leathery. We listen to the stomach, the actual organ of the stomach. We do that every single time we intubate to make sure we're not pushing air into there. You listen to the small and large intestine, and you're listening just for movement, right? You're listening for those clicks and gurgles. The renal arteries, believe it or not, they seem like they'd be small and deep, and they are very deep and actually very small, but it's, in theory, it's possible to hear bruits there as well over the renal arteries. Somebody already said fractures. We listen to the aorta. You don't hear anything over the aorta unless it's dissecting or has an aneurysm. Fetal heart tones, normally we hear with a Doppler, right? We use a Doppler for that. But it is possible after 18 weeks, if their little back is up against kind of the anterior wall of the abdomen, to hear fetal heart tones. I've never been able to do that, but textbook-wise, it's possible. And then we talked about dialysis fistulas. So how to hear? We are visual people, right? Humans are very, very visual. We navigate the world almost entirely using vision. Some by listening, right? If you're out for a walk, you're looking for cars, and you also would hear them coming up from behind you. But in general, we rely tremendously on vision, and so hearing is pretty underdeveloped as compared to like other animals, unless you practice at it, right? So anytime we have a student come through the program that's really good at heart tones, like right off the bat, what do we know? We know that they're probably musicians, right? They've spent time thinking about sound. And thinking about sound is something that I've enjoyed over the last 5 years making a podcast, because I've been doing editing, audio editing. That's all I'm doing is listening to audio. And so things I used to not be able to hear when I listen to other people's podcasts, now I can hear, the dog shaking and the collar rattling, or I can hear them kind of thump the table a little bit, things that I clean up and edit out of my podcast. And so it's just by practicing that, by training that, I hear more. And so that's something that we do with our students is we spend 30 minutes teaching them, practicing how to hear. So what does that mean? That means sitting still long enough to listen. So like right now, if we were to all listen to our environment, I'm going to give you a couple of minutes just to listen, just to hear. And what you'll notice, I'm going to quit talking in a second. What you'll notice is that you hear one thing and your ears almost kind of zoom in on it. Like I hear my clock, and then if I kind of zoom in on it and focus on it, it gets louder, and the other things kind of go away. But then if I start noticing, oh, my computer fan's going, then I hear that going and I hear the clock less. And that's the same thing we do when we're listening to lung sounds. You're having to filter out maybe talking that you hear in the background, the heart beating, right? And you zoom in and out by focusing your attention on different sounds. So I'm going to give you a minute to listen to your environment. Maybe type in the chat what you hear. I'll type what I hear. Mm. You guys maybe have heard of like acoustic tiles. You can put up kind of baffling around to absorb sound. People do it in audio studios and things like that, to dampen sound, kind of external noises that you don't want in your audio recording. Well, people have created kind of experimental kind of physics testing of things, of these quiet rooms that have these huge, huge acoustic tiles that absorb almost all sounds. And people can go into these rooms, and it almost is a little bit, some people get nauseated and they have trouble with their balance. And it basically absorbs any audio information at all about where you are in space or anything like that. It's very disorienting to people. And what they found is that some people, when they're sitting in this room, they can hear their own heart beating. They can hear their own, they've said they hear, I've not done this, I've just read accounts of it. They said they can hear kind of blood swooshing through their body, maybe like close to their ear or something. Maybe, I don't know, it's interesting because I'm sitting right here and I can't hear that, but I can only assume that's because other sounds are taking up that information. My hearing got really good with the podcasting because with audio editing, I had a visual representation of the audio, right? I look at the wave file and it's these little peaks, and it matches what I'm hearing. And so I would see a little blip on there. I'm like, what's that blip? And then I would go listen to it and focus. But it takes time and practice. We've been auscultating each other, right, in medicine for over, the stethoscopes existed for over 200 years. Hippocrates talks about auscultation directly on the chest, like you see in this picture, and he lived like 500 BC. So we've been trying to figure out what's going on in the body by listening to it, because we didn't have any imaging. When I say we, I mean humankind. They didn't have any imaging. And so they just wanted to know what was going on in there. And they thought, well, let's put my ear to the chest. And what Hippocrates listened to was almost exclusively lung sounds. He didn't ever comment on listening to the heart, interestingly enough. Around 1800 is when the stethoscope was invented, although I've kind of jumped, because before the stethoscope, they figured out to not have to touch the person directly. Sometimes got strange, right? When you've got like mixed genders or extreme difference in age or children, they wanted to kind of create some modesty for the patients. And so they figured out if they rolled up some paper or used like a dowel of wood, if you scrape a dowel of wood on one end, you can hear it on the other end. And so they would put that to the chest to listen. And then the stethoscope was invented in 1800. And this is what one of the earlier ones looked like. And this is a modern day stethoscope. And it has a bell and a diaphragm on it. And I want to talk some about what the difference is between those two. Your stethoscope, the one you have, may or may not have a true bell. And they've done studies about what are bells or diaphragms better to hear the heart or the lung sounds. And what they found actually is they're actually not that different. People make a point to say that the bell is better at hearing deeper tones, like bowel sounds. And the diaphragm is better at hearing higher pitched things like wheezing. But in actuality, you can hear both with either. So you may not have a bell on your stethoscope. And you also may have the Littman technology. It's important that you know kind of how your stethoscope works because there's so many different kinds now. Littman's, most of them don't have a true bell. They've got a diaphragm that changes depending on how much pressure you push on the skin, right? So if you just, and this is a picture of a Littman stethoscope, if you just place it on the chest, light pressure, it works as a diaphragm, but if you push hard, it works as a bell. So there may be two sides, a big one and a little one. That just is for chest size, right? Adult and pediatric. And as you guys know, you rotate that thing around to select which side you want it to be on. In the introduction, I talked a bit about, the time you're most likely to pull out your stethoscope is to take a BP on a call, right? And long sounds. I'd say those are the two most common times. You may be using a non-invasive, oh yeah, Bill and Kim are talking about digital stethoscopes. I didn't really comment on those. There's electronic stethoscopes now that enhance the sound. I've not used one, I've not bought one, but I've used some of my students, and they're pretty cool. They have like ability to record and things like that. It's really cool. When you're listening to the brachial artery, when you're checking a blood pressure, what you're hearing are called Korotkov sounds, right? And it's the sounds that it's almost like you're hearing a bruit because you're creating turbulent blood flow by pushing on an artery, right? By partially closing it, you can hear the blood rushing by. And where we place this, the stethoscope is important, right? So you've got the brachial artery, and then that bifurcates. You can see right on the, it would be, I guess, the right side of your screen. You can see the humerus and then the radius. So that's where the elbow would bend, right? Just distal to the antecubital fossa, it bifurcates into the radial artery and the ulnar artery. If you catch it before it bifurcates, that's usually where we want the stethoscope to land. And the way to know where that is to palpate first, right? So that's kind of a fundamental that you may have forgotten because you're just used to throwing on the NIBP, right? The non-invasive blood pressure cuff, and it's just been a minute. And it works 90% of the time just to throw the stethoscope in the AC and you hear it. But on people that it's difficult to hear or the NIBP doesn't work well, right? The way to go back to the fundamentals is to palpate that artery and feel it and place your stethoscope directly on top of it. The NIBPs, I will comment on those just for a second. The non-invasive blood pressure cuffs connected to monitors are very good. They've gotten better. There are limitations, and the manufacturers say this, they have limitations when you have extremes of blood pressure. So when it's incredibly hypertensive or incredibly hypotensive, they become less reliable. So they're really great on healthy people. They're doing well with their blood pressure, not so much when they're really, really sick. And I've seen this at the trauma center here more than once, right? They have trouble getting a blood pressure because the person's blood pressure is so low. And I've watched the tech work so hard to get a really good auscultated blood pressure, and it's hard. And they often end up getting a palpated blood pressure because it's just hard to hear. There's a lot on this slide, but I like it as a reminder of kind of like what are we hearing, right? When you inflate the cuff, right? When you 100% occlude arterial blood flow, no sound can be heard through the stethoscope, right? You're not hearing anything. It's when you start letting off the pressure and it's partially closed, that's when it's this arterial pulsatile blood flow. That's when you start hearing it. And then again, when it's fully open, there's no more turbulence, there's no more bruits, the blood flow is silent again because it just flows through easily, right? That's the principles of what you're hearing. And rather than just inflating that thing up super, super high, one practice, when we talk about blood pressure measurement techniques, right? Kind of best practices, is to put the BP cuff on, and before you start inflating it, or as you're inflating it, put your hand on the radial pulse, and as you're inflating it, inflate it till you feel the radial pulse go away. And then you don't end up overshooting them super, super high, right? You don't pump it up to 220 when you really only needed to go to 90 or 100. It saves time, it saves patient discomfort. So that's one tip for blood pressure techniques. Some other stuff that I want to make sure I review is the cuff size. So if the cuff is too small for the patient, which is often the case, lots of bariatric patients in America, we're often needing to go to that large adult cuff. If it's too small, you get a higher reading than what their actual blood pressure is. If the cuff's too large for them, you get a lower reading. Right? So make sure you pick the right cuff size for the patient. The cuff location, I did a little reading. I told you guys in prep for the lecture just because I needed to refresh. The location should be about an inch to 2 inches above that antecubital fossa, right? So above the crease in the arm. The cuff tightness, put it on tight, but you should be able to slip a couple of fingers under there as well. So not, not super, super tight, but plenty tight so it doesn't fly off of there. Palpate the brachial artery to figure out where to put your stethoscope, and then get a palpated blood pressure while you're inflating, right? So you have a sense of where we are, right? Where's our ballpark? And this is another thing to kind of help you, like, when do I start listening, right? Because there's so much going on in EMS calls. Lots of communication, lots of patient movement, patients talking, they're moving. Just having a hint of where you're gonna know to, like, okay, when it hits around 90, that's where my palpated blood pressure, that's where the radial pulse went away. I'm really gonna perk up and, like, really, really listen there and expect to find it there. And then another important principle is for the slow heart rates, which you'll already know if it's slow or fast because you palpated that radial pulse as you're inflating. Remember to deflate slowly, right? So don't let the air out too fast on bradycardic patients, because the worry is that between those beats, you're dumping out too much air too fast, right? So you have to go slower, deflation for slower heart rates. A blood pressure is communicated as a systolic blood pressure over a diastolic blood pressure. And that simply means what is the pressure in the arterial system during systole, right, when the heart is squeezing, versus what is the pressure in the arterial system when the heart is at rest during diastole. That's very, and it's a snapshot of time, right? It's just in a moment. What is the blood pressure in a moment? Literally that moment when you're taking it. The AHA recently came out with some guidelines for blood pressure. It was pretty heavily scrutinized, but these are the current, because they thought it was pretty aggressive in terms of, like, what they're calling hypertensive. But really, people's blood pressures, their systolic blood pressure should be less than 120 and diastolic less than 80. I remember about 10 years ago, I had a friend that wanted to become a flight attendant, and they would not hire them if their diastolic blood pressure was over 90, because it was such a prognostic of a really poor kind of overall health. So systolic blood pressure says what's happening during systole. Diastolic blood pressure is kind of like the overall tone of the vascular system, and it's actually, your diastolic pressure is a pretty good indication of your overall health. And when it gets elevated, that is not a good thing. So they've gone through, and these are your numbers for those. So anything over 120, considered not normal for systolic. Anything less than 80 is what you're looking for healthy. You see at the bottom, we've got hypertensive crisis greater than 180. Another thing to think about as you're looking at blood pressure is what is their pulse pressure. right? It's just one more little nugget of info that you can think about from that snapshot. You already have the data, right? So let's talk about pulse pressure. Pulse pressure is the difference between systolic blood pressure and diastolic blood pressure, right? So think of blood pressure of 120 over 80. Their pulse pressure is 40, right? This is just simple subtraction. And a healthy expected physiological pulse pressure, it's expected to be a third of the systolic blood pressure. So going back to that 120 over 80, a third of 120 is 40, right? So that is a healthy pulse pressure. So 40 is not the key number, right? 40 doesn't equal healthy pulse pressure. Healthy pulse pressure equals a third of whatever their systolic, right? All right, so okay, what's unhealthy mean? What do we care about that, right? Some conditions present with what's called either narrowing or widening of the pulse pressure. So that number can either, the difference between those numbers can either get bigger or less. And there are conditions in our world that have kind of hallmark feature of a narrowed pulse pressure. The one that I really want you guys to think about is that hemorrhagic shock presents with a very small, narrow pulse pressure early on. Long before their blood pressure drops, they get a narrowed pulse pressure. So the patient whose systolic might be 110, and you think, that's great, that sounds lovely, right? Their systolic's 110, I'm happy with that blood pressure. Well, if they're 110 over 90, that's a narrow pulse pressure, and it's one of the earliest signs of hemorrhagic shock. So you've learned that things like anxiety also are, and tachycardia are early signs of shock. Another one to add to that list to like just perk you up just a little bit and make you wonder, might they be bleeding and I don't know it internally, is a narrow pulse pressure. Now, there are other things that can cause it, but it's just one more thing to add to your bucket of possibilities. Another way that we talk about blood pressure is to talk about mean arterial pressure, the MAP. And mean means average, right? It's an average over time. And so mean arterial pressure measures, it factors in, it's an equation that factors in the fact that we spend more time in diastole than systole. So your heart contracts, squeeze, that takes about a third of a unit of time, and then it's at rest for 2/3 of a unit of time, right? So we spend more time in diastole with our heart at rest. And so there are a couple different ways to do the formula. If you have a monitor, you don't need to know the formula, or if you have an app on your phone where you can plug in a blood pressure, it will calculate a MAP for you. But the simplest one I've done, the one that works for me, is to think about MAP in this way. I just say, okay, what's their diastolic blood pressure? And then I add a third of the pulse pressure. So do the 120 over 80 patient, that's 80, right? Diastolic blood pressure, plus a third of the pulse pressure. 120 over 80, the pulse pressure is 40, so a third of that is maybe 13, right? So that gets me up around 83. A normal MAP, right? A normal mean arterial pressure is 70 to 100. When MAPs get below 60 is when we consider like, ugh, maybe end organs are not being perfused. Right? You already know what hypotension looks like, right? You know what a low systolic blood pressure looks like. Well, now this is just one more data point to add to your kind of looking at vital signs, because you probably, depending on what monitor you probably have a monitor that calculates MAP for you. So in every single one of these monitors, there's a MAP displayed. So, Sean, can y'all see my little mouse moving around?
Yeah, we can.
Beautiful. So top left, right? We've got heart rate. Notice heart rate's always green. We've got pulse ox. It's always blue. We've got respiratory rate in this one, and then you've got blood pressure. This patient's blood pressure is 128/76, a MAP of 26. That's interesting to me. Huh. This patient, top right, the thing in parentheses is the MAP. So 69/38 is 51. That is a terrible blood pressure and MAP. And you already looked at it and thought, I hate that blood pressure, right? But now you can know if that MAP is below 60, they're not perfusing end organs like kidneys, skin, GI tract. Like things are going to start not being good for them, for their end organs soon. I think I cut off my slide a little bit here, but we've got 91 MAP over here. And then on this simulated monitor, you've got a MAP of 59. Let's talk about heart tones for a bit. My suspicion is this is an area that you may have learned once or twice, and then or never. And it's just kind of like, yep, that's hard. Moving on, and it is hard. To me, you know, you've heard of Beck's triad for cardiac tamponade, includes muffled heart tones as one of the 3 findings. To me, all heart tones are muffled. Like they're hard to hear. They just simply are. And patients with a lot of tissue, right? It's difficult to hear them. Where do you listen? There are 4, sometimes actually 5 locations on the chest to listen to heart tones. If you're having trouble in one area, you can try another. And these locations are specific to ideally you're hearing one of the 4 valves the loudest in these areas. Okay, but I'm just happy when I hear a clear S1, S2, right? So, yeah, Jordan and Bill said ape to man. So that's a mnemonic. I've not heard that mnemonic, but it's a mnemonic to remember what you're hearing in these locations. So you've got the aortic area, which is not on the side of the chest where the heart is, right? But that's where your aortic valve, you hear the best. So it's just right of the manubrium. Pulmonic valve, just left of the manubrium. And if you're hearing the aortic and the pulmonic valves, that's when the blood is leaving the heart. So that's where you hear loudest, the S2, right? Because it's at the end. Right, so S2 is the second sound, the dub, right? You've got lub dub, S1, S2. S2 is heard best up high, right? S1 is heard tricuspid and mitral areas. Again, just left of the sternal border. Try to go between the ribs, intercostal spaces. And then the E, that ape to man, is between these 2. There's a 5th location called Erb's Point. The first place I usually listen is the pulmonic area, because what I'm listening for is clear S1, S2. I'm trying to not hear murmurs, but there are other things that I'm going to talk about here in a second that you can hear. You shouldn't listen over clothing. Chest hair like this can actually make it pretty confusing. You guys have probably been confused with lung sounds and stuff. People are super hairy. If you have any movement, it can sound like crackles or kind of friction. Same if you've done it over clothing, which we've all done it, but we shouldn't do it over clothing when possible. So lub-dub, S1, S2. The S1 represents the AV valves, the mitral and tricuspid valves. So AV stands for atrioventricular, right? So it's the valve between the atria and the ventricles. S2 represents the semilunar valves, the aortic and pulmonic valves. You can get, these are some different sounds that you can hear. You can get split S1 or a split S2. Split S2s are pretty common, and it has to do with the pressure in the pulmonary system. The valves don't close at the same time, basically. They're not synced up. You can hear an S3 that comes right after S2, and that's when the patient's volume overloaded. It's just an additional sound, right? S4, you hear, actually S4s come right before the S1, which is strange. And it's when you have like ventricular wall stiffness or hypertrophy. The murmurs happen kind of throughout or as part of S1 or S2, and they sound like swishing. And then you can hear friction rubs as well. So I talked about the fact that when I'm editing the podcast, I see the wave files, and it helps me hear. And when I learned heart tones, someone did me a great gift. There's this system to learn heart tones. They did me a great gift of letting me look at a computer-generated image of the heart tones so I could understand what I'm hearing. And so I could look at this and listen at the same time and expect, oh, S1 is probably louder than S2. Or S1, these are actually pretty equal in length, but maybe sometimes S1's shorter than S2. And it shows you the sequencing of, you've got lub-dub, pause, lub-dub, pause, right? And that helped me tremendously. You can find all this stuff on the internet. Presenting audio to you guys through this presentation wasn't going to be real good. I wanted to let you hear sounds, but I didn't include it in this presentation because I just don't know what type of audio you have on your end. But there is tons of it online if you want to go listen to heart tones and lung sounds. So let's talk about lung sounds, because that's something I think more than heart tones, you guys are listening to lung sounds. You've got somebody with shortness of breath, and in the out of hospital setting, we don't have chest x-rays, right? We don't have chest CTs. We don't have the ability to see what's going on there. And so just like Hippocrates, it's like we're desperate to try to figure out what's going on. I am going to show you a chest CT because I think this is the equivalent of looking at a audio file. It's like now you can see what you're hearing, right? So this is a chest CT. At the bottom of the screen is the lumbar spine. So CTs look from the feet up, and you're looking at the vertebrae on the bottom of the screen. As you come up from the vertebrae, that's the mediastinum in the middle, that's the heart. And then you've got lung tissue on either side. This little bit at the top of the screen is the body of the sternum. And then you've got skin and fat all the way around. So when you listen anteriorly, right, we can hear lung sounds. And when you listen posteriorly, you can hear lung sounds. And you should listen both anteriorly and posteriorly. When patients are sitting up, I go for the back straight away. And in fact, I start in the bases, right? And the reason I start in the bases is because sometimes people can have atelectasis, they can have collapsed alveoli. And I want to know that because it sounds like crackles. I want to know that before they've done a bunch of deep breathing, right? So if you do a proper respiratory kind of lung sound exam, they're doing a good bit of deep breathing, right? And so as they do that, the lung sounds change over time. And so I want to hear the bases first because I'm wondering if, they start taking some deep breaths, those alveoli are going to pop open and then the crackles are going to maybe clear out. Okay, so I listen, my auscultation is posterior bases, and then I work up the back and then to the front when possible to get to the back. This is a CT. I wanted you to see if you can conceptualize kind of in your brain what I'm trying to show you here. Again, vertebrae at the bottom. This is a CT, a slice of a body. You can just kind of look at the bottom left. This, or the bottom right, they're the same. They just put blue stuff on here to illustrate something. This is actually a COVID patient. The bases of the lungs extend so inferiorly that if you're listening from the front, things like the big liver are in front of your lung fields, right? You're not hearing the bases of the lungs if you're listening only anteriorly. And this picture explains why that is. Right? If I put my stethoscope here, I'm not going to hear any lung, but there's totally a lot of lung down here, right, in the bases. And what you guys know about things like pulmonary edema or a pneumothorax or things like that, a lot of this stuff is dependent, meaning the fluid, if they're sitting up, the fluid is going to settle kind of to the bases, and you want to detect that by listening posteriorly. So if you take nothing else from this CE, maybe it's just a reminder. Maybe the only thing you take away is a reminder of like, hey, I gotta get back to listening on the back, right? Of patients that I really don't want to make them sit forward or lean forward or whatever. It really is worth it to get to hear the bases of the lungs. I didn't used to look at CTs, but I just started looking at them, and they've kind of opened up a whole world for me of like understanding what I'm hearing, what I'm seeing, what I'm percussing. The picture on the left is a pneumothorax, possibly a tension pneumothorax, because it's starting to kind of really push on the mediastinum, and you can see that this side of the chest is super inflated, right? It's hyperinflated. If you were to listen, right, if we put our stethoscope on this person's chest, what you're going to hear is nothing, right? You hear absent lung sounds. So this is a really large pneumothorax. This is air in the pleural space. And you should probably hear nothing, right? The patient on the right side of the screen also has a pneumothorax, but it's a smaller one, right? So you could listen on this side of the chest and still hear lung sounds. And so people talk about these lung sounds as being diminished, right? A way to differentiate a tension pneumo from a simple pneumothorax is as the lung sounds get increasingly absent, right? You start to worry, oh, maybe that's a tension pneumo under there. And this kind of CT illuminates that, I think. As you listen to lung sounds, these are the lung fields. This is where to put your stethoscope. And notice it kind of goes in this little Z pattern, right? We're going back and forth, side to side. And that's so you can compare. I mean, the great thing about the human body is we're mirror image bilateral, right? So you can compare one side to the other. If you compare lung sound, number 1 to lung sound number 10, those are apples and oranges, right? You don't expect to hear the same thing. But if you compare field 1 to 2, now you're comparing apples to apples. Okay. Notice on the front they avoid like the big pecs and breast tissue. On the back we're avoiding the scapula. All right, so getting in there where we can hear lungs. If you're going over kind of the scapula, you're not really going to hear lung sounds. Also notice that, look at these lung sounds 1 and 2 on the anterior side. You have the ability to hear lungs on the neck. So above the clavicle are the apices of the lungs. right? You can actually, they've got a little bit of lung tissue there. I want to talk about what you expect to hear in these regions, right? So 1 and 2, we expect to hear, this is really kind of where you're listening for lungs, but then also for stridor. 3, 4, and 5, 6, you're kind of listening for, these are the main stem bronchi, so you're listening to see if you hear bronchi, which I'll talk about in the next slide. As you start getting into 7 and 8, we start wondering if we're going to hear some wheezing. And the ones in the bases, you hear what's called vesicular sounds. That's the healthy sounds. It sounds just like rustling air going through the leaves. Okay. And leave your stethoscope on for the full duration of the inhalation and exhalation, right? I've had enough physical exams in my life where I've just felt the clinician listening when I'm inhaling, and the second I start exhaling, they take it off and move it. And I'm like, well, you didn't hear the end of exhalation. And what happens at the end of exhalation are some of the earliest kind of signs of wheezing, right? At the very end of exhalation, you can get the wheezing in the more minor reactive airways. So lung sounds, stridor, we discussed earlier. Stridor goes with narrowing of the kind of the larynx, the trachea, right? This is if you have airway swelling or something in there. So stridor is a musical sound that mostly happens on inspiration, right? So you've got a lot of kind of pulling pressure, pulling that air through when it's narrowed, and you get a little bit of a musical squeak. And it is, of all of these sounds, it's the last one I want to hear because it means the airway itself is swollen. And it takes a lot to create stridor. It takes a good bit of swelling. It has to be pretty narrow to become stridorous. So things that cause it: foreign body airway obstruction, infections like croup or epiglottitis or bacterial tracheitis, right? Infections of the trachea or the epiglottis, the laryngeal structures, particularly in kids. And then airway burns, right? You get swelling and then allergic reactions as well. That's where you see stridor. Wheezing is what you hear when there is what's called bronchoconstriction, right? Constriction of the bronchioles, the tubes right before you get to the alveoli. If they are narrowed, you get wheezing. And I choose that word carefully. I say narrowed, right? Because it isn't always asthmatic kind of reactive airway, smooth muscle constriction that causes it. Sometimes wheezing happens in like pneumonia, for example, because there's stuff down there and those little airways are kind of narrowed by secretions, right? Or you've heard of maybe cardiac wheezing. When people say cardiac wheezing, they're talking about the narrowing of bronchioles that can occur when there's pulmonary edema. So wheezing does not equal asthma. And I know you've heard that before, right? It's kind of a staple thing that we say in EMS, that wheezing does not always mean asthma. What it means is that they have narrowing of the bronchioles, a common cause of which is asthma. But there are other causes, things like pulmonary edema, pneumonia, bronchitis, toxic inhalation, allergic reaction, right, that can cause wheezing. And you've probably been taught as well that wheezing on expiration is less scary than wheezing on inspiration. I tend to subscribe to that as well. Usually, if you hear it on expiration. It just means they're having trouble getting air out, but they're not having trouble with the inflow. As bronchoconstriction increases, you kind of go from expiratory wheezes to both inspiratory and expiratory wheezing to, at worst, then you get a silent chest where there's very little air movement. So you've heard that not all wheezing is asthma, right? It's also true that not all asthma wheezes. So there's something called cough variant asthma. People with proper reactive airway disease, proper asthma, that just for whatever reason, they don't get wheezy, right? They cough instead. So disconnect wheezing and asthma in your brain. Don't make them line up as just like perfect Siamese twins, right? They often go together, but they are not kind of synonymous. Rhonchi is a lot like wheezing in the sense of the problem is in the same location. Rhonchi is usually a little bit bigger airways, right? A little bit bigger than the end bronchioles, right? A little bit more proximal in the airway tree. But it's what some people call a lung snore, right? It's a little, almost like a vibration, and it sounds or it represents that there are secretions in there. Kind of like if you've, sucked in through your nose and you've got snot in your nose and you kind of get a little snore. It's just like that, only in the lungs. It's air going across secretions, often secretions that are like from infection. So rhonchi accompanies bronchitis big time. And rhonchi can be cleared. That's a fundamental difference between rhonchi and these other lung sounds, is that with a good cough, or if they can expectorate that stuff, right? If they can cough that stuff out or clear it out from a smaller airway into a bigger airway, it can go away. And so that's kind of a hallmark feature. If you're hearing, people talk about wet lung sounds, this can sound wet. You can tell it's like, oh, there's gunk in there. And they clear it out. That's a secretion, not pulmonary edema like fluid, like congestive heart failure, okay? Rails and crackles, people in different parts of the world, different textbooks at different times have used different words for those. But this is that popping, kind of crackly sound that you hear at the very end of the respiratory tree. It's in the alveoli, and it occurs when there's fluid in there or swelling, or you've got alveoli that have collapsed, right? I've heard people say that if you take a little bit of your hair and you kind of twiddle it between your fingers close to your ear, that's what crackles sound like, and I totally agree. Sounds just like that. These are usually dependent. So if they've been sitting up, right? If there's fluid in there, if there's going to be crackles, it's going to be in the bases. Or if they've been laying on their back, right, it'll be all along the posterior. If you roll them on their side and listen to lung sounds that way, it may be, it kind of can move around like that if it's fluid. A pleural friction rub is when you have irritation of the pleural lining, and as they breathe, you hear a rub, right? It sounds like kind of hands rubbing together, or rough surface rubbing together. I said the last one I want to hear is stridor. I also don't want to hear absent, absent sounds. I want to hear air movement, right? If someone's wheezing and I can hear wheezing or rhonchi, it's like, cool, air is moving around in there. It's going in and out. And absent lung sounds can mean a couple of things. It could mean a tension pneumothorax. Some people very rarely have lungectomies, right? Very rarely. So they may not have a lung on that side. Or it could be that their airways are just so swollen shut, so closed down that you're just not getting any airflow. right? And that's when things get scary. Silent chest. It's not what you want to hear. While we're talking about lung sounds, I thought I might throw in the vital sign of pulse ox. And specifically, I think you probably know a ton about your pulse ox, right? It's probably something you use on probably almost every call. You're getting often a heart rate off of it. It's just a reassuring number. You just throw it on there and you've got it. But I wanted to talk a bit about something not everybody uses as much as they could. If you have the ability to see what's called a pleth wave, right? The wave at the bottom. You may be looking at your pleth wave just to let you know that you have a good reading, right? When it's tall, mountains like this, real consistent across the monitor, it's like, cool, my pulse ox is reading and the number on there is valid, right? When you get a wonky pulse ox sometimes, right, if you get it in the 70s and the 80s, you don't like it, the next thing to think is, I'm going to look at my pleth wave, right? Because if it looks like the one on the screen and it's in the 70s or 80s, it's correct. So one thing about vital signs is that when they're good, we assume the monitor is correct. But when the vitals are wrong, bad, when we don't like the number, we assume that there's some type of technical glitch. And more often than not, there is not a technical problem. It's a real number. Now, things that can mess up your pulse ox are like if you're getting a blood pressure on that side, right? You see your pleth wave go away, the number drops. It's like, okay. That's why you normally try to put the pulse ox on the other arm than the BP cuff. What can make the pleth wave not good, what can make the pulse ox not read well is if they're not getting good circulation to that site, right? So if there's an injury or if their blood pressure is really low or an injury to the arm or something like that, or they have some type of vascular abnormality, right? You want to switch it to a different location. But when I look at pulse ox, I want to see that pleth wave too, and I want to see that it looks like the one on the screen, because then I know, okay, that's a valid number. One thing I'll mention, because it's not, again, it's just something to kind of enrich your understanding of what you've got on your monitor, is there's a little notch in a pleth wave, and it's called a dicrotic notch, and it's expected in normal. What's happening there is it represents a very short period of time when there's a little bit of backflow in blood flow right after the aortic valve is closed. Interesting physiology, but basically you should expect to see that little notch. It's normal. Heart rate, what's normal? What's a normal heart rate? I bet you guys have great answers for that. And I bet I'm thinking of you guys that have been doing it a long time, and you say things like, well, it depends on the person, right? What's normal for them, right? Are they on beta blockers? Are they a triathlete, right? A trained athlete? And I think that's a great first question to ask yourself, is like, what's expected for them? This is kind of how I think about heart rates. I'm letting you just look at it and think what I might be trying to say here. So 0 to 60 is considered bradycardia, right? It's slower than we expect the SA node to fire. But we also know that cardiac output is a function of heart rate and stroke volume. So cardiac output equals stroke volume times heart rate. So if somebody's stroke volume is really, really good, stroke volume being the amount of blood that comes out of the left ventricle. If somebody's stroke volume is great and they're squeezing out a bunch of mLs with each squeeze because they have a really efficient strong left ventricle, then they can lower their heart rate. And that's what we see with super athletes. And they still maintain a perfectly fine cardiac output. But in the average person, we really expect their heart rate, to be over 60. That's because of how often the SA node fires on its own. 60 to 100 is considered normal, kind of expected heart rate. When you get over 100, we call that tachycardia. But there are different kinds of tachycardia, and I know you guys know this because you've run enough calls and you're like, there's tachycardia and then there's crazy fast, right? So you've had the trauma patients or the anxious patients or the patient in pain or the, patient with kind of mild infection or something like that. And you see their heart rate 120, 130. It's like, yep, they're tachycardic. And it's expected. That's compensatory tachycardia for some illness or condition. When the heart rate in adults gets over 160, we start to worry. We start to wonder, right? It is not an equal sign. It doesn't mean what I'm about to say, but we just start to think to ourselves, might this be a primary cardiac problem, like a dysrhythmia? So anything 100 to 160, we think, that's compensatory tachycardia, right? They have some conditions, sepsis, heat exhaustion, hypovolemia, dehydration, right? That tachycardia is compensating for a drop in blood volume often. But when it gets over 160, we just think to ourselves, could this be a primary cardiac problem, like a conductive pathway that's gone kind of haywire? Is this a dysrhythmia? It's not an automatic. You've probably seen patients in extreme sepsis or extreme heat stroke whose heart rates can get up crazy fast. 190, right? 180. And they're still in a sinus rhythm. There's nothing wrong with their heart. In fact, their heart's doing everything right by being that tachycardic. But over 160 in adults is when you think, could you ask yourself, could this be a primary heart problem? Those last two numbers on the end are pediatric numbers. So that same thought process of, okay, is this heart rate compensating for a problem or is it the primary problem? Is 160 for adults, 180 for children, and 220 for infants. It's kind of the cutoff. Now, there's numbers on this slide, but they are not rules, right? These are just help guide your thinking. You may have heard of a max heart rate, right? The max, if you were to max out your heart rate at the gym, is 220 minus your age in years. So take a 40-year-old, right? We don't expect them to really be able to get their sinus heart rate over 180, right? So that's another formula you can use to think, is this heart rate compensating for something or is it the primary problem? I have, let's see here. Boop. I have some questions to ask. Sean, is it okay if I go into my questions?
You are the boss. You feel free whenever you are ready.
I'm the boss. All right, let's do this. Boop. All right, so your stethoscope might have a bell. They all have a diaphragm, right? The diaphragm is the flat kind of drum looking side. And it's best to use when you're trying to hear high pitch wheezing, true or false? Put it in the chat. Cool, you guys are answering true. I agree. I learned when I was doing a little research for this lecture that I've always used the diaphragm for the blood pressure, but some of the sites I was reading, they're recommending using the bell. But the more and more I dug into this diaphragm versus bell thing, it turned out that they're not that different, right? But the bell is a little bit better for hearing deep, deep tones like vowel sounds, heart tones. Question 2, wheezing always indicates that the patient has asthma. True or false? Yeah, and then so bonus questions. It is false. So now you guys tell me what else can wheezing indicate? In general, it means that the smaller airways are narrowed. And so what conditions can cause that narrowing? Good. Yeah, I didn't mention COPD much in this lecture. Kind of glad you brought that up. So COPD, there's kind of two main presenting types that I'm sure you've heard of chronic bronchitis or emphysema. The chronic bronchitis, for most people, it precedes the emphysema. They get these chronic respiratory infections because of exposure to some toxin, most commonly smoking. And they just get the goblet cells just get irritated and they get hypersecretion, they get secrety, right? They just secrete lung boogers all the time. They can wheeze because, again, it's just narrowing. They get rhonchi and wheezing. And then with emphysema, they have a lot of difficulty getting the air out because they've literally destroyed airways and alveoli and things like that. It's a destructive lung disease. And so they get wheezing as well. Pulmonary edema can wheeze. Pneumonia can wheeze. Allergic reaction. Good, good. Question 3, pulse pressure equals systolic blood pressure minus diastolic blood pressure. True or false? It's true. And we normally expect a normal pulse pressure to be 1/3 of the systolic blood pressure. Hemorrhagic shock results in a wide pulse pressure, right? So hemorrhagic shock would result in a big difference between the systolic and diastolic blood pressures. True or false? Good. The reason it happens, the reason it narrows, right? It's false. It doesn't widen, it narrows. The reason that happens in early hemorrhagic shock is because of shunting, right? You've learned that people shunt away, right, from the skin, the GI tract. And to shunt like that, that means they've closed off. They've closed off capillary beds, and that means they've constricted the arterioles that feed those capillary beds. And so when the heart is at rest, right, during diastole, the vasculature, because of epi, is incredibly constricted. And so the diastolic can actually come up a little bit when people have lost, like as compared to their normal blood pressure. So maybe their normal blood pressure, 90/50, right? Maybe really healthy, small adult, right? 90/50 is just their resting blood pressure. And the day that they lose a bunch of blood, all of a sudden, all at once, all of that epi just vasopresses everything, squeezes everything tight, and they see a little bump in their diastolic blood pressure as a result. You couple that with a drop in systolic, right? During systole, if the heart isn't filling with enough blood, right? If there's a loss of blood volume, you don't get that good stretch of the ventricle. They're not good preload, right? So you have a little bit of drop in systolic, a little bit of increase in diastolic, and it becomes narrow. And it's a Sherlock Holmes way to really root out some pretty early hemorrhagic shock that a lot of average medics might miss. And trend that, right? And I know you guys know that with vitals, trend it. Is it getting increasingly narrow? All right, last question. If a BP cuff is too small, and it often is too small, the BP reading will be falsely high or low. That's right, it'll be higher. I didn't really build any slides for bowel sounds, but I did mention that you can listen to the intestines. Kind of a typical practice for that would be to listen in all 4 quadrants and just listen long enough till you hear movement. Particularly with somebody with an abdominal complaint, right? So we worry about things like bowel obstruction. Bowel obstructions can be absolutely terrible, deadly. And if people aren't moving, right, you want to know that. Bowel obstructions can be a little tricky though, because everything past the obstruction actually can clear out pretty fast with diarrhea and stuff. So you may get a little hyperactive past it. But when the bowel gets kind of quiet and slow, we worry. And by slow, I mean, you can listen for a nice 30 seconds to a minute. As long as you're hearing a little bit of movement in all quadrants, they're good to go. If any of you guys have ever been in the hospital or a family member in the hospital after surgery or something like that, right? You get a lot of narcotics and things like that, slows down the GI tract, and they will not let them go home until they're passing gas and pooping, right? So things need to move along. The opposite of that is you can get really hyperactive bowel sounds. as a feature of some conditions like allergic reactions, right? We think of allergic reactions as being like a respiratory problem, but it's really a whole body problem, right? You see the hives. Anywhere you've got a capillary bed, it can basically get leaky. And so you've got histamine in the GI tract and they get hyperactive, bowel sounds, diarrhea. You guys, I'm sure, have heard with anaphylaxis and such. All right, that is it for my prepared lecture. What questions do you have about vital signs and auscultation? Yeah, great question. So the placement of the BP cuff is important, right? You want to get it a little bit above the fold, an inch, 2 inches. But the placement of the bladder is important as well. Absolutely. With the bladder having the marker on there, almost all BP cuffs have that little marker of lining it up with the artery, right? So make sure you put that thing on lined up right. I'm curious how many of you guys are using NIBP as a way to measure blood pressure only. Our students kind of come back from the field and they say, yeah, like they just throw on the NIBP cuff and it's over. But to me, best practice is getting an auscultated one at some point just to make sure they're matching up. Or if the NIBP cuff is having an extremes, like high or low, I like listening to just to cross check. Yeah, the NIBP cuffs, I've seen them used on the lower arm in the hospital. And I think we could do it too on the forearm and then check a radial pulse palpated. If we didn't have NIBP and you want to use just a manual one. I've absolutely seen them do that. I don't know if, I think it's working with what you got in that case. I don't actually know how it affects the accuracy. I can't speak to it for sure with evidence and science. It's interesting that you'd go to the ankle. I like the forearm better than the ankle. I remember when I was in the field, they had thigh cuffs too. What was that about? Why are we using thigh cuffs? Thigh cuffs? Are we doing that? Oh, right, when they don't have arms. Or their arms are broken. That's good. Thank you.
I feel like that was a very simple answer to a complex question.
Be careful with the pediatrics too, sizing their BP cuffs. Although we don't rely too much on BP for kids. We love the heart rate on kids as kind of the primary way to know if they're doing all right. We didn't talk about capnography. Do you guys have it?
Without anybody talking to you, Ginger, my guess would be unless a lot of these agencies are pretty rural, so I highly doubt. I mean, I guess it just depends, obviously, the agency, but without those monitors, obviously. Those of you that have cameras on, Stevens County, I can see you guys. Diamond Fire, I can see you guys. Whitman County Fire District 6, do you guys have heart monitors at all to be able to utilize the Untitled CO2 technology? Diamond Fire is shaking their head no. Whitman County Fire District 6, what about you guys? Colfax does. FC EMS 1. Is that Ferry County? Perfect. So looks like they've got it. Curlew's a no. Brogan, do you guys have it in Stevens County at the ambulance up there? Entitled CO2? No. All right. Sheridan Medical Hospital, I think, is SMH. I think they're out of Montana, Ginger. Looks like they've got it.
Yeah, if you're intubating, you gotta have the waveform capnography. But if you're not, I can see how different agencies might not. Cool. We won't go to it. We won't go into the capnography then. I think that's all I got, Sean.
Perfect. That was awesome. Thank you so much. Our next EMS Live at Night is the 24th of this month. The topic is going to be busy bee. This is more on anaphylaxis, emergencies, and so on. Cameron Murphy from Spokane County Fire District 9 is back. He was the presenter from last time that did sugar beetus. So he's on board with some of these catchy little names. So he's back with talking about anaphylactic emergencies. Ginger, do you remember off the top of your head when you are back with your thinking chest pain lecture?
I thought you were going to ask me what the topic was. It's chest pain, but I think it may be January.
I think so too. But kicking off 2020 awfully strong, or 2021, I guess, awfully strong. So awesome, guys. Well, feel free to hang around for a few minutes. If you got any questions for Ginger or any closing things to say. But other than that, be safe. We will see you guys hopefully on the 24th of November. Have a good night, guys.
Thank you, everybody.